topic, which is Hodgkin lymphoma. And thank you so much to Dr. Nayak for detailing the treatment of relapsed refractory Hodgkin lymphoma and also the role of transplant, because I don't have to go through all that now. Um, so let me start by talking about the learning objectives. I'm going to briefly touch base about the historical perspectives, epidemiology of Hodgkin lymphoma, diagnosis and workup, and then treatment for advanced stage Hodgkin first, because it's a little easier than discussing treatment for early stage Hodgkin lymphoma. And we'll briefly touch upon the options for relapsed and refractory disease. And then we'll talk also briefly about survivorship, because that is very important in Hodgkin lymphoma. This is one of those diseases where we do achieve a high cure rate. So I always like to start with this slide just to remind everyone that this is not a new disease. We have known about Hodgkin lymphoma for more than 2 centuries now. It was first described by Dr. Thomas Hodgkin in a seminal paper in 1832. But he didn't call it Hodgkin lymphoma at that point. The term Hodgkin lymphoma was actually defined by Dr. Wilkes, who quoted Dr. Hodgkin's paper in 1865. And then in the 19th century, we got a little bit more understanding about how does Hodgkin lymphoma manifest, and terms that we use every day, like Pell-Epstein fever, Reed-Sternberg cells, were all devised in the last actually 2 centuries ago. Ann Arbor's teaching was in 1971. And then if you look at the treatment paradigm, most of the major treatments that we use at this time were devised in the 1960s and 1970s. So Dr. Kaplan was the one in 1962. He showed for the first time that radiation can be curative in Hodgkin lymphoma. And then the group from NCI, led by Dr. Emil Fry, devised the regimen MOMP, which was in use for a long time. And Dr. DeVita applied it in Hodgkin lymphoma in 1970, and he showed that you can achieve remissions in Hodgkin lymphoma. And then the ABVD regimen was actually published in 1975 by the Italian group under the leadership of Dr. Gianni Bonadonna. And then for 50 years, there was really no movement in the management of Hodgkin lymphoma until 2011, when brentuximab was approved. And as you've heard, brentuximab is an antibody drug conjugate. This was quickly followed by the approval of checkpoint inhibitors, nivolumab and pembrolizumab, which has really been a game changer in the management of Hodgkin lymphoma. So coming to epidemiology, it's not a very common disease, but it is very famous because it is a poster child of lymphomas in general and cancer, and the chance of cure with multi-agent chemotherapy. So there's a bimodal peak. Patients are young, but also the incidence does go up in those who are above 55 years of age. And it is overwhelmingly more common in whites, more so in Europe. And that's why you see these huge groups from Germany publishing all this data in Hodgkin lymphoma of thousands of patients. Risk factors, no clear risk factors have been implicated, but we all know that there's an association with immunocompromised states, EBV, HIV, some relationship to pesticide use seen more in farmers. Rarely there is a familial aggregation. And then first degree relatives do have a 5-fold increased risk of getting Hodgkin lymphoma. Pathologic classification, I'm still quoting WHO 2016 because the latest iteration of WHO is very controversial with the simultaneous release of the ICC classification. But Hodgkin lymphoma did not really take a big hit that way. So it's still pretty much the same. There's classical Hodgkin lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. For classical, there are 4 types, but we really don't treat them any differently. And nodular lymphocyte predominant Hodgkin lymphoma, which I will not be discussing today, is treated more along the lines of low-grade B-cell lymphoma, such as follicular lymphoma. Another thing that you already know is that the Reed-Sternberg cell is the prototype for diagnosis of Hodgkin lymphoma. It's a large cell. It is a B-cell derivative with the classical owl's eye appearance. It's really easy to make the diagnosis of Hodgkin lymphoma, CD15, CD30, and CD25 positivity. And the cells are usually negative for CD45, PAN-B, S100, keratin, and EMA. The one thing I always tell my trainees is that while most lymphomas can be diagnosed on core biopsies, for Hodgkin lymphoma, this is one of those where the more we have to listen to the pathologist, and the more tissue you can get, the better, because the Reed-Sternberg cells can be anywhere between 0.1 to 10% of the whole inflammatory infiltrate. There is a rare variant called syncytial type of Hodgkin lymphoma where you do see a lot of more Reed-Sternberg cells, but that's pretty rare. So classification, again, you are no stranger to this slide, stage 1, 2, 3, 4. I just always counsel patients and trainees that Hodgkin lymphoma, like other lymphomas, is highly curative even in stage 4 disease. Now coming to something which is more specific to Hodgkin lymphoma is risk stratification. In Hodgkin, we always have to balance the treatment in terms of efficacy, but also in terms of toxicity because of the very high cure potential. So it's always important to tailor treatment based on what kind of risk the disease carries. So there are many different risk stratifications. This is the latest iteration from NCCN, just trying to simplify it a little bit. What it says is that, well, stage 3, 4 is advanced stage disease and has a totally different treatment paradigm. But in terms of early stage disease, the way to remember it easily is that if a patient has constitutional symptoms, it's unfavorable disease. If a patient has ESR more than 50 or more than 3 sites, it's unfavorable disease. And then everything else is favorable disease. Why this is important is, of course, you have to give much less treatment for favorable disease rather than even early stage unfavorable disease to achieve the same results. And this is just a pictorial diagram because it's kind of difficult to grasp it otherwise. So as you see, the first cartoon is favorable disease, which has just less than 2 sites of disease, and when the lymph nodes are small. If you have a huge mediastinal mass, then it is stage 2 bulky, unfavorable disease. Same thing if you have a huge lymph node more than 7 centimeter, it is unfavorable disease. If you have more than 3 lymph nodes, it is unfavorable disease, and of course, stage 3 and 4 disease comes into the advanced disease paradigm. The other way of figuring out the risk in Hodgkin lymphoma, especially for advanced stage disease, is the IPS score. So the IPS score is actually really old. It was first described in 1998 by Dr. Hassentlever, where there were 7 different parameters, and there was a nice separation of curves based on what your score was for the lymphoma. So of course, the first question is, well, this is so old and now the treatments have advanced so much. So does the IPS score even carry weightage in the current era? And this was looked at in 2012. And as you can see, all the curves have migrated upwards, but it still looks like IPS can predict outcomes even in the modern era. So that's something that we use for risk stratification. And then the last thing that we use is the Duvel score. I'm sorry. So the PET response. So I'm sure you're familiar with the Duvel score. I'll briefly go over it. Duvel score is basically Duvel score. There was another score called the IHP score before Duvel score. So if you're reading PET-based studies before 2008, you have to be careful by what criteria they're using. They're either using Duvel or IHP because there are subtle differences. So in the IHP score, everything was compared to the aortic blood pool. But in Duvel score, it is compared to the mediastinal blood pool and the liver. Score of 1 is basically if there are any residual masses, but they are less than they're equal to the mediastinal blood pool and less than the liver. Duvel score 2 is if it is more than the mediastinal blood pool, but less than the liver. Duvel score 3 is if it is equal to the liver. Duvel score 4 if it is greater than the liver, and Duvel score 5 is if it's a new area or much higher than the liver. In Hodgkin lymphoma, again, most of the new studies consider Duvel score of 1, 2, 3 as negative, but some of the older studies consider only Duvel score 1 and 2 as negative. And that's a slight nuance that should be kept in mind while interpreting any data on Hodgkin lymphoma. So how do we use this information is looking at the prognostic significance of interim PET. So you started treatment on a patient and you made a decision when you started treatment, but then you can recalibrate the treatment after 2 cycles by how a patient is performing. So as you can see in this, if the PET scan after 2 cycles is negative, no matter what kind of treatment you do, there's a 90 to 95% chance of success. And if the PET scan is positive after 2 cycles, this is historic data where the chance of success was only 30 to 35%. We have improved compared to that, but it's still very important. And patients who have a negative PET scan after 2 cycles do fare worse than those who have a positive PET after 2 cycles do fare worse than a negative PET scan. So moving on to pre-treatment workup, most of the tests are pretty routine and same as what we do in other lymphomas. What is unusual is that we add a ESR to be able to calculate the risk in early stage Hodgkin lymphoma. I always check HIV because it is a risk factor. And then PET CT you're going to do, of course, for staging. And if you're planning to use ABVD, you're going to do an echocardiogram and lung function. Most of these patients are very young, so we always talk about fertility preservation. And that is something that I personally forget many times. And this is something that is very important to patients if you talk to them. And lastly, bone marrow biopsy. We used to do it a lot. I reserve it now for very unique cases where a patient has PET positivity in the marrow, but it could be inflammatory. It's a young woman with iron deficiency anemia, and I can't really tell whether the PET is the SUV is elevated because of that, or actually presence of Hodgkin lymphoma in the marrow. In terms of treatment planning, as I had alluded before, it is very important to toxicity with the chance of a cure, because the reality is that 80 to 85% patients of Hodgkin lymphoma will get cured, and they will have to live decades, 50 to 60 years, and deal with the side effects of treatment. So let me start by talking about advanced stage Hodgkin lymphoma first. So just a derivative from the NCCN guidelines. So so my preference was the ABVD per the RATEL approach, which I'll describe further. But now with the 6-year Echelon 1 study data, which shows an overall survival benefit of brentuximab with AVD, I have switched over to brentuximab and AVD in most patients. I have stopped using escalated Birkop. However, it is there for patients if they have very, very aggressive disease, if they have lung involvement and you want rapid disease control and you don't want to use bleomycin upfront, because in Birkop, bleomycin is given on day 8. So let me walk you through the key trials that helped me make this decision. So this is the RATEL study that I've mentioned. So as you can see, there are 2 parts of the RATEL study. The first, all patients start with ABVD 2 cycles, and then the PET is negative after 2 cycles. You follow this path, which is you randomize patients to ABVD times 4 versus AVD times 4, and the other path is those patients were escalated to Birkop. And what this basically showed is that it didn't matter. So you could safely drop bleomycin if PET2 was negative. And of course, because we dropped bleomycin, the side effects went down, the risk of neutropenic fever and respiratory AEs went down. In terms of PET positive patients, even though the PET positive side was not randomized, you do see that the 3-year PFS and OS are much higher than what I'd shown you in the previous slide with PET positive patients, where the outcomes were only like 35%. So definitely you can tell this study shows that escalation to Birkop was better compared to historical controls. Now coming to the Echelon 1 study, which basically compared BV-AVD 6 cycles with ABVD 6 cycles. Important to note that they did not use PET scan at all in the study. Interim PET scan, I mean, they just went through and through. So actually, this is a good idea in resources where you may not have resources to do a PET scan in between and make a decision accordingly. And what basically the original publication was fraught with a lot of controversy because they used this outcome called modified PFS. But then recently, the 6-year data showed that there was an overall survival benefit where patients who got ABVD had a 75% overall survival, 75% PFS compared to 82% PFS with AAVD. And in terms of overall survival, the benefit was a little more modest. It was about 4%. So 90% OS with ABVD and 94% with AAVD. But still, in Hodgkin lymphoma, where the bar is already so high, it's just very hard to show OS benefit. So this was a very pleasant surprise to see this data. And based on this data, if a patient is young and otherwise able to tolerate treatment, AAVD, the preference should be AAVD. Now, what is the problem with AAVD or BVAVD, whichever you prefer, is the side effects. So it increases the cost by a lot because brentuximab, of course, is expensive, but also you need mandatory GCSF prophylaxis, and that adds to the cost exponentially. If you give GCSF, then the incidence of neutropenia is about 11% compared to 7% of ABVD, which is not bad. Also, peripheral neuropathy is a big issue. Um, but the good news is that it is dose dependent and it does come down after patients finish treatment. So at the end of 5 years, even though 1 out of 5 patients have peripheral neuropathy, the most of that is very low grade neuropathy, and very few incidents of grade 3-4 neuropathy. And as expected, because you're not giving bleomycin, pulmonary toxicity incidence is very low. Now, what was not captured in the study, and there's a lot of real world data that is coming out, is BVAVD is just hard to tolerate in terms of fatigue. Patients just feel crappy on BVAVD, which is very different from ABVD. So, in older adults, BVAVD all by itself has been very hard to give. So it is, it is the treatment of choice as such. But in my practice, what I'm doing is, if patient has a low IPS disease, like IPS of 1 or 2, where I know that they're going to be fine with ABVD anyway, then I really don't give them BVAVD. I just stick to ABVD because I know they'll have a much better experience during their treatment. Then we wanted to look at BVAVD and PET2 positivity in the long term, and it looks like we have still not been able to catch up. So if you see the PET2 positive patients, which are the bottom two curves, even with BVAVD, 5-year PFS is only 60%, and in ABVD, it's only 46%, which is pretty bad for Hodgkin lymphoma. So, so we want to do better. We want to do better than BVAVD. So that is where this study, that is where checkpoint inhibitors come in. So the preclinical data behind checkpoint inhibitors. So this is a data set from Stanford, which shows that basically having any aberrations in 9p24 makes the disease poor risk, and those patients perform worse. So based on this premise, this was a small phase 2 study that was published in JCO in 2019, where they looked at 51 patients, and the 51 patients received Nivo AVD, and the ORR and CR were okay, but just based on this data, there's a huge randomized trial that's currently ongoing, Nivo AVD with versus BV AVD. And this trial is pretty remarkable because it is not just adults. It also includes patients who are above 12 years of age. So this is one of those very rare studies where the pediatric group and the adult cooperative groups have come together. It's a 1,000-patient study which has completed accrual, and we may get some results even during this year about whether Nivo AVD can surpass the benefit of BV AVD and may become the new standard of care for advanced stage Hodgkin lymphoma. Now, what about our older adults, though? Like I mentioned, patients above the age of 60, the disease is not the problem. The tolerance of treatment is a problem. And this was demonstrated by this publication as early as 2013, where they showed that there was a huge difference in outcomes in patients less than 60 and more than 60. And most of the difference in outcomes was not like patients who had disease progression. The difference in outcomes was for patients above 60 who did not even have disease progression. They basically fared so poorly because of side effects of treatment that their overall outcomes were very bad. So what were the things that to worry about in patients over 60 was neutropenia, bleomycin related lung toxicity, which was as high as almost half. And there was a 9% treatment related mortality. So the same author, Dr. Andy Evans, well, I'll come to him again, but so can we do away with ABVD is the question first. The problem with doing away with ABVD is that we really take a hit on PFS. So if you try to use BV alone, then you do get high responses, but the median PFS is only 10.5. BV Benda was not a good idea on older adults. BV dacarbazine, again, it worked, but it was just not enough to provide a cure. And BV Nivo is a good option. It is an option for older adults, but the PFS is not mature. We don't have enough survival data to say that it is a curative regimen. So in this scenario, Dr. Andy Evans, his group basically designed this sequential BV-AVD study, where it's a very long course. It takes about 9 months to deliver the whole treatment, because you're giving BV for 2 cycles first, then you're doing your 6 months of AVD, and then you're doing BV again for 4 cycles. But what he showed was that the event-free survival and overall survival are very, very high in older adults. So in my practice, maybe not above the age of 60, but definitely in any patient who's above the age of 70 or who has a lot of comorbidities where I know that ABVD or BVAVD is going to be too much for them, I've moved to doing sequential BVAVD in these patients, and they do very well usually. They just get super tired, bored of seeing you after 9 months of finishing, after 9 months of being in your clinic. That's all. All right. So this was the easy part, which was advanced stage Hodgkin lymphoma. I'm going to talk about early stage Hodgkin lymphoma, and I might have to skip a few slides because this is a very, very complicated topic. And I may not be able to do justice to the topic in about 10 to 15 minutes. So as I've mentioned before, early stage Hodgkin lymphoma, this was a very long-term data that basically showed that as decades go by, the risk of recurrent lymphoma, which is the line in red, plateaus. But these survivors, they keep having increased secondary malignancies and increased cardiovascular events. In fact, the cumulative incidence of breast cancer in women who were less than 35 years of age, who were treated for Hodgkin lymphoma, just is unacceptable. So we have to be very cognizant of finding the sweet spot in treating early stage Hodgkin lymphoma. So most of the studies are focused on that. So how can we do that? Well, so first is risk adapted therapy, which is, the early stage favorable versus unfavorable. Then the response adapted therapy, which is basically look at the PET2 and see whether you can cut down on treatment or do you have to escalate treatment. And then obviously, eventually, everybody's looking at novel agents to see how we can move the field forward. So this is again a reminder of the risk stratification slide. Why I put up this slide in addition to the previous slide is that everybody is using their own risk stratification. So depending on which group study you are reading, whether it's the German group or the EORTC group, you kind of have to be mindful of what risk stratification they used. So even for me, who sees a lot of Hodgkin lymphoma, every time I have a patient with early stage Hodgkin lymphoma, I just look. I cannot rely on my memory to just remember all this. I just look and make sure which pathway I'm going to use. So let's talk about mortality treatment first, and then we'll talk about PET adapted treatment for each of these situations, which is early stage favorable, early stage unfavorable, and early stage bulky. So this was a very important study in early stage favorable disease. What they did was basically the Germans made 4 groups, 2 cycles of ABVD versus 4 cycles of ABVD, 20 gray radiation versus 30 gray radiation. And what they basically showed is that radiation and 2 cycles of ABVD is enough. The curves basically superimposed. In early stage unfavorable, they kind of tried to do the same experiment using ABVD versus workup and 20 gray radiation versus 30 gray radiation. But in this case, 30 gray radiation won. So basically, ABVD times 4 and 30 gray radiation was good enough. You didn't have to do any more. So then they also wanted to look at, well, can we cut down? So what if we did 2 cycles of ABVD and 2 cycles of VCOP and compared it to 4 cycles of ABVD? So they actually showed, all the studies, just as a caveat, show that VCOP is better, 5% better almost in terms of efficacy. But we've never been able to show an overall survival benefit with VCOP. So the Europeans love VCOP, but at least in the US, we just don't give VCOP because it's so hard to get through. And there's a risk of infertility and secondary malignancies in the future. So based on these 3 studies, basically what you can do is for early stage favorable, you're good with ABVD times 2 with 20 gray. For early stage unfavorable, you can choose ABVD times 4 with 30 gray. Or if you're really, really worried about the patient, you can do escalated VCOP times 2, ABVD times 2 plus 30 gray. And the same for early stage bulky. But now the question is, what if you don't want to do radiation? What if the disease is in the chest and you want to avoid radiation? You don't want to do combined modality. You want to do only chemotherapy. So that's when further studies come in. So again, I'm showing this slide to show that PET scan can be used to adapt therapy. So if a PET scan is positive, patients will do well no matter what after 2 cycles. And if a PET scan is negative, then you got to rethink your treatment plan. So the rapid study, they use this. And what they did was they did ABVD times 3. And if the PET scan was negative, you stop. You don't need to do anything. But caveat here is they defined PET scan negative as only dual 1 and 2, not dual 1, 2, 3, which we are used to doing. So if you're going to use the rapid study, you have to be careful about that. So what they found was that ABVD times 3, even though there was a slight PFS benefit, the overall survival benefit was same. So ABVD times 3 is good enough if your PET scan is negative. So then the CALGB 50604 kind of did that, similar, but they did the PET scan after 2 cycles. And what they showed was that if you do a PET scan after 2 cycles, then if your PET is positive, then escalating to escalated BACOP times 2 and RT is a better idea. So now the studies are getting more and more complicated. So the H10F study and the H10U study, basically, they try to answer too many questions all at once. I'm going to try and walk you through the data. So first of all, they wanted to look at the favorable group. And as you remember, in the favorable group, we had decided that, if you do 2 cycles of ABVD and if the PET is negative, you can well, so the standard of care at that time was you do 2 cycles of ABVD, and then regardless of whether the PET is positive or negative, you do 1 cycle of ABVD and RT, and you're done. So they tried to randomize it. They made 2 arms. So basically, if your PET is negative, you do not need radiation, was their premise. And if your PET is positive, then we will escalate you to be a COP, was the other premise. In the unfavorable group, what they did was that they kept the 2 cycles of ABVD and RT, but here they compare it with 4 cycles of ABVD and the beer arm. So basically, what they showed was that if your PET is positive, then it does support escalation to BACOP. So that was basically one of the big things to take away from this study. Further studies showed that if your PET is negative at the end, you don't really need RT, even if patients have bulky disease. And this was a very important study because this is what we have adopted. If it doesn't matter if you started out with bulky disease, if your PET became negative, then we don't do radiation anymore. So, well, let me just move on to the treatment paradigm based on all these studies. So this was what we talked about before, is if you're not going to use PET scan at all, just use combined modality treatment. But if you're going to use PET adaptive therapy, then if you have early stage favorable disease and you don't want to give radiation, then you can use rapid study. So you just give ABVD times 3. But remember that here PET was defined as dual 1, 2. If what do you do if your PET scan is dual 3? Then you use the CALGB 50604 study. So what you do is you don't stop at 3 cycles of ABVD, but you give 4 cycles of ABVD. In your early stage unfavorable disease, you can either do 4 cycles of ABVD and 30-gray radiation. You can start with escalated BACOP and then you can de-escalate to ABVD with 30-gray of radiation. Or you can do CALGB 50604, which is just the same thing. Is you do, if your PET is negative, you do ABVD times 4. In your early stage bulky, I generally tend to use the RATHL approach because those patients were included in the RATHL study, and it's just so much easier for me. Is you do 2 cycles of ABVD, you do a PET scan negative, which it is in like 80 to 90% cases, then you just finish out with 4 cycles of ABVD. So like this is the same data, but this is in early stage if your PET2 is positive. So, like we talked about, if PET is negative, that's all great. You do whatever way you cook it, it'll be fine. But if the PET is positive, here's what you do. So if it's early stage, ABVD times 2, PET positive. If it's dual 3, then you do ABVD times 2 per CALGB or AVD times 4, which because it is considered negative. Dual 3 was considered negative in those studies. If your dual is 4, then you can do ABVD times 4 and radiation. or you can just do escalated workup times 2 and or radiation, or if you don't want to give radiation, disease is in the chest, then you do escalated workup times 4. And then if it's bulky, then the alliance study did add radiation, but like we talked about, is like it's probably not necessary to do radiation. If it's dual 5, then you're talking about disease progression, and you can go ahead and treat this way, but you really need to change course and talk about second line therapy at this point. So this is just a slide for inclusion purposes, is to basically show that the story hasn't stopped here, and now we are incorporating novel agents. But all these studies, even though they show amazing responses and amazing PFS, are too early, and I've not adapted any use of novel agents like brentuximab or nivolumab, etc., in my early stage Hodgkin lymphoma patients yet. And this is another slide showing that we need a randomized study to really change paradigm in early stage Hodgkin lymphoma. So this is a study which is ongoing, which is the RADAR study. So briefly talking about treatment in second line therapy and beyond. And I'm going to be brief here because this is like a whole separate topic in itself. And thankfully, Dr. Nayak has covered the role of transplant here. So just a few salient points. So even with all that we do, 1 out of 3 patients may have a disease relapse or develop primary refractory therapy. But this will change, hopefully, with more effective first line treatment. I always biopsy my patients before doing second line therapy because I've seen so many surprises with sarcoidosis or gray zone lymphoma that you always want to confirm with a biopsy. Second time when you do treatment, the chance of cure is about 60% in Hodgkin lymphoma. What are the risk factors for failure? If you have a patient with primary refractory disease, if you have stage 4 disease at relapse, if a patient has bulky disease, if you take a patient to transplant with a positive PET scan, which means partial response, and if you have extranodal disease, or if it took more than 1 line of salvage to get a patient to remission before a transplant. So what are the different salvage therapies? So traditionally we have used ICE, DHAP, GVD, just chemo-based regimens, and all these studies were done in the pre-PET era. So even though the response rates and CR rates seem really low, that's because the response was all based on CAT scan and not the Lugano criteria based on PET scan. So they're not as bad as they look here in the slide with the CR rates, which are that low. However, what are the other candidates in relapsed refractory Hodgkin lymphoma? So this is a slide showing kind of just the response rates of all the single agents that have been studied in Hodgkin lymphoma mostly. And as you can see, the top 3 candidates for combinations are checkpoint, nivolumab and brentuximab and pembrolizumab. So everybody is doing various permutation combinations of combining checkpoint with all these chemotherapy backbones. So you have seen this data with BV ICE, Nivo ICE, Pembro ICE, BV, GVD, everything. So the regimens that have been real blockbusters are 3: Nivo ICE, Pembro ICE, and Pembro GVD. I don't like to use BV ICE, even though it has very good responses, is because it's just too toxic. So I'm going to show you some of the data that I've used in my practice. So first of all, if you're planning to use a chemo-free option, BV Nivo is a good option, but the overall response rate and CR rate are not the best. The overall response rate is 85% and CR rate is 67%. Contrast this with the previous data. If you add some chemotherapy, ICE or GVD, which is the bottom part of the table, then you see that the complete metabolic response rate is up anywhere between 85 to 95%, which is so much better than just BV Nivo. Of course, Nivo ICE and Pembro ICE are on the toxic side. So my favorite regimen is Pembro GVD. And this was published before I joined MSK, so I have no loyalty to this regimen. It's just I was using it even before that because it is very well tolerated. It's all outpatient. Patients don't require transfusions. They think it's even easier than ABVD. Even though it was a very small study, the overall response rate was 100% with a CR rate of 95%. So based on this amazing result, while the standard of care is still to take patients for an auto transplant once they go into remission, there is a study that is ongoing which is randomizing patients to pembro maintenance. So we'll see what the results of those studies show is whether challenging transplant in the second line setting is going to be effective. But right now, the what I do in my practice is Pembro GVD followed by auto transplant. If Pembro is not available, you could technically do Nivo GVD. Also, I don't think there's much difference between Pembro and Nivo. And Nivo is given every 2 weeks, but in the BV Nivo study, Nivo was given every 3 weeks. So you could technically give Nivo every 3 weeks and get away with similar results. But if somebody wants to do that study and publish data to inform everyone, that would be really amazing. Um, then do you stop after transplant? So in the subgroup of high risk patients, I invoke the ETHERA study where we give brentuximab maintenance for 1 year. And it did show a progression-free survival benefit. Uh, Most patients don't finish 1 year. They say bye-bye after about 9 doses because of neuropathy, and they just get tired of it. So we actually recently put together a real-world analysis to see what is happening to those patients, and it looks like it doesn't matter. Like patients who got more BV versus less BV, they all did the same. So I don't really push my patients to finish the 1 year. It's just PFS benefit. So if their neuropathy gets really bad, I don't want to worsen their neuropathy just so that I can get some more theoretical benefit out of brentuximab. So this is basically the treatment paradigm of relapse refractory Hodgkin. Is of course we always encourage clinical trials here in the US. You could do BV based therapy, but I personally prefer PD-1 based therapy. We do PET scan after. If PET scan is negative, then patient should go for transplant. If PET scan is positive, then consider additional salvage and then transplant. BV maintenance in high risk patients. And then if a patient has progression after that, then in the randomized study of BV single agent compared to Pembro single agent was superior. So my next line of choice would be pembrolizumab. But then again, clinical trials, brentuximab, lenalidomide, everolimus are all options. But it's a huge unmet need is when a patient has seen both checkpoint blockade and brentuximab is like they don't really have much options in the salvage setting to really get them back to a CR. One slide about survivorship. It's very important that these patients either follow up with an oncologist or the survivorship clinic who really knows what to study them for, which I know is a big problem in many settings. But if they got radiation, especially in the neck, they need to have yearly TSH, carotid artery ultrasounds, chest radiation. I've personally seen patients with I've personally seen patients with coronary artery disease and breast cancer after getting treatment for Hodgkin lymphoma. So this is something they all should be counseled on, and lung cancer screening too. And we don't do splenic irradiation anymore. Otherwise, they would have needed vaccines too. And this is only in adults. If you look at children oncology group guidelines for adolescents, it's much more extensive. So with this, I'm at my final slide. Key takeaways. Early stage Hodgkin lymphoma, combined modality therapy is most effective, but PET adapted therapy balances efficacy with long-term toxicity. Advanced stage Hodgkin lymphoma, BV-AVD was associated with a survival benefit and is now the preferred regimen, but you must use growth factor with BV-AVD. And then in relapsed Hodgkin, second-line therapy with autologous stem cell transplant is still standard, with BV maintenance to be considered for high-risk patients. Thank you so much for listening to me. I know I'm the last speaker before dinner. So I really admire your patience, and I'm happy to take any questions, or you can email me or, message me on Twitter or whatever you prefer.
Excellent, Dr. Pallavi. So, my question is related to Pembro GVD MSKCC regimen. So, if the patient 300 milligram per meter square of anthrax, 6 cycle AVD, like adding liposomal doxo, have you faced any situation where you develop a cardiac toxicity, the Pembro GVD? Because if somebody has already received 6 AVD and then relapsed, then you're adding liposomal doxo again. That is first question. And second question is, are you happy giving 4 AVD if very favorable? Because from the H10 data, from the H10 data, European H10 data, there is 10%, close to 10% decrement in survival if you don't give RT in early favorable. So, no RT approach by giving just 4 AVD. What is your thought on that?
Yeah, so you're asking a very good question. Is that was exactly my question to the MSK people about why did you choose GVD? Because you've already given these patients doxorubicin, so why did you choose GV? Like Doxil. So honestly, I didn't get a very clear answer. It was just that it was an outpatient regimen, and they had some preclinical data showing synergy with pembrolizumab with GVD, but they haven't noticed any cardiotoxicity. The doses are very low, and they're doing only 2 to 4 cycles of GVD with this regimen, so it's not like there's too much anthracycline exposure. You would still probably stay within your lifetime exposure for anthracycline, so that's the reason. And also the other thing is most patients with Hodgkin, they are young, so they haven't really differentiated the data between young and old adults to see if the number of patients was really low to show if older adults fare any worse in terms of cardiotoxicity. But that's something that we definitely need to study in larger subsets. Can you repeat your second question? The voice got a little bit cut off, so I
In
couldn't
early
hear.
favorable, in early
Yeah.
favorable Hodgkin, you have told 4 ABVD if PET negative and no RT.
Yeah.
So from H10 data, in early favorable, if you omit RT, even if you give 4 ABVD, there is close to 10% decrement in failure-free survival, which is not seen
Yes.
in favorable. So that's the question.
Yes. So agreed that there is a benefit in PFS, but there was no overall survival benefit. That's why we don't usually. So that's the thing, right? Is it's still an option, but because there was no overall survival benefit, depending on where the disease is, you really can get away without doing it.
Thank you. Hi, ma'am. The question is after Pembro GVD, you transplant, but patient relapses and he is not eligible for pembrolizumab therapy. So would you consider Pembro or any other immunotherapy?
So that is the big question, right? If you use up all these novel agents upfront, what are you left with when the patient has a disease relapse? And are you really changing the natural history of the whole disease where these regimens won't work later? We don't know. It all depends on how soon after the patient has a disease relapse. If the patient was responding to Pembro GVD when you took them to transplant and they achieved a CR, then I would definitely reuse it in the relapse setting. What I don't know is if it is less efficacious then. Although other data has shown that Pembro retreatment has worked in other malignancies, so I think it will work. But again, like the efficacy, do you really reach that 90% ORR, 70% CR rate? I don't know that.
From the keynote data that I've shown in the Pembro single agent, there they have re-challenged even after stopping after 2 years and those who relapsed. So there is a response, but definitely lesser than that. But that's the only data keynote
Exactly.
data.
Absolutely.